and that's the way I like it, and that's the way I like it. Your body's a dream that turns violent, and that's the way I like it, and that's the way I like it. The winter is long in the city, and that's the way I like it. So please, baby, please, open your heart, catch my disease. I was backstage in Pomona, and that's the way I like it. She drank beer with Coca-Cola, and that's the way I like it, and that's the way I like it. She'd tell me about the winds from Santa Ana.
Hello, folks. Can you all hear me? Did you like starting with music this morning? It's a good change. Okay, welcome to online seminar 4. Yun, do we have you there?
Yes, I'm here. Good morning, everyone.
So did everyone finish the crossword? All right, we'll move on. So today, what we're going to cover in the online seminar is we're going to go through...
Sorry to interrupt you, Matt. Have you got the updated version?
Yes. I've just changed it slightly, but yeah, I do have the updated version. Yep. So today's seminar, guys, we're going to go through a couple of MCQs that weren't done overly well in the quiz 1. So we're going to go through those. We've got a couple of case studies to give answers to. This has been requested by students during the week. This is from last week's module. There's an SAQ question that Yun will go through. This is important because, as we said, maybe last week or the week before, 40% of your final exam will be based on SAQs. So it's important that you understand how to answer SAQ questions and you know what is being asked of you. And then you want to give a quick overview of the immune system, which again has been requested by a couple of students. So that's what we're going to do in the next 50 minutes. What's coming up? So this is really over the next week, basically. So next week's seminar, I put a poll out. I'm not sure if you guys saw it. It was either on it's one of the pages, Facebook or Teams. I put it out and I just requested when you wanted the seminar to cover the assessment 2 item. So next week we will do a whole seminar on your concept map assignment. Okay, so please try to attend if you can so you can ask your questions. But it'll be recorded like the other one. So if you aren't able to make next Monday, the reason why, one of the reasons why I guess a lot of students voted for next week is because the week after there's a whole group of students that will be on placement. So that was the majority when we accumulated both the Facebook and the Teams page. This week's tutorial is going to be very important for the assignment as well. So as you know, this week we're starting module 4, which is neoplasm. So this is cancer. And as you hopefully you know by now, your assignment, the topic, the diagnosis is a type of cancer. So I would strongly encourage you to attend your tutorial this week. If you can't attend, there is the Wednesday online tutorial that's from 4 to 6 that's run by Yun. You're welcome to attend. That will be recorded. So for those students who can't make either the face-to-face, the online, there's that option of the recorded. But it would be much better if you can be there for the synchronized session, either online or face-to-face. And we have a quiz that's due by Friday, 5 p.m. So there was a few students that said the old study guide had a different date, but that's been updated for some time now. So if you thought it was next week, it's actually this week. So Quiz 2, which will assess Module 3 and 4, opens Wednesday 5 p.m. It's open for 48 hours, and it closes 5 p.m. Friday. So don't forget that. So these are the main things that are coming up this week, basically, or the next 7 days. Ewan, do you have anything further to add?
Yes, just one more thing. Last week, I've received some feedback from students that they would very much like past sessions to cover the content that they're assessed on in the quizzes. So I've sort of communicated that and discussed it with the past leaders. And in this week's past sessions, your past leaders will cover both modules 3 and 4, which are the 2 modules that you'll be assessed on the quiz. So I just wanted to add that, Matt.
Okay, thank you. Nicole, did you have a question? You set your hands up. No? Okay. All right, I think that's all I had. I was going to say something. The Tuesday tutorial. So this is tomorrow at Gold Coast. I sent you an email out yesterday. So those have been cancelled just because Jackie is likely to have COVID. So we had to cancel that. But as I said in the email, you're welcome if you're in the Tuesday tutorial. So it's I think 8 to 10 and 1 to 3. I think you're welcome to attend any tutorial during the week. There's some today. And there's some Thursday and Friday. So if you can't attend those, there's the online one, which is 4 to 6 p.m. Wednesday. If not, that will be recorded. So sorry for the inconvenience, but Jackie, the tutor, has been exposed to COVID, but she's doing fine. Okay, let's get started. Or any questions from you guys? Pop them in. Put your hand up and put your microphone on. So you're welcome to do either. Are there any, is everyone still out there? We haven't heard any activity. Oh, there we go, new message. Okay. Okay, no questions? All right, so I'll move on. So I'll let Yun take over from this point and then I'll come back a bit later.
All right, thanks, Matt. Okay, so just to have a go at this multiple choice question, let's just see if everyone knows what the answer to this one is. It's one of the typical sort of questions regarding the immune system. So which of the following cells is not part of the innate immune system? Let's see what your answers are in the chat. A, B, C, or D? Obviously, this question is asking you whether or not you know the difference between the innate immune system and the adaptive immune system. Looks like we've got a consensus. Everyone's saying A, someone said B. Okay, very good. Yes, so the correct answer for this one is B, lymphocytes, A. Now, obviously, I'll give you an overview of the excuse me, immune system, and I'll also be talking in detail about each of the different immune cells that you can find within the innate as well as the adaptive immune system. Let's just move on to the next slide, Matt. I think that'll be, yep, there you go. Hopefully everyone can see the slide. So this is a good sort of overview chart of both the adaptive and the innate immune system. Now, you'll notice that it says acquired instead of adaptive. They basically mean the same thing. So if we start from the right side of the chart, so within the innate immune system, you've got the physical barriers, which are basically your first line of defense. So you've got things like skin, mucous membrane, saliva, urine, tears, the stomach acid, etc., which basically stops the infection from, or the pathogen, any foreign particles and pathogens from entering the body. Now, being your first line of defense, these are very non-specific, meaning that it doesn't really differentiate the specific types of pathogens. It will just try to stop anything that's foreign to the body. Let's move on to the next lot. No, not the next slide. So you've got the blood-borne immune system within the innate, and this involves your phagocytes. Now, phagocytes is a big umbrella term that includes your immune cells like neutrophils, macrophages, basophils, eosinophils, natural killer cells. And although it's not specifically stated in the chart, you've also got your mast cells that trigger, that initiate the inflammatory response. Okay, so you've got all of these that are part of the innate immune system, which is basically your non-specific first line of defense. Okay, when I say non-specific, it obviously means that it doesn't really differentiate, or it doesn't really recognize specific pathogens. Hopefully that makes sense. Hopefully that's a good summary. And we'll look at each of these phagocytes in more detail in the next few slides. And then you've got your acquired or your adapted immune system. Okay, adaptive immune system obviously includes two main immunity, which are your T cell immunity and your B cell immunity. T cell immunity, they usually are called cell-mediated immunity, and these occur when you've actually got the disease. Whereas with B-cell immunity, they're called humoral. Humoral meaning that it involves bodily fluids. It's got the antibodies and the memory B cells. And as we know, with memory B cells, it's going to aim for future or subsequent infections or invasions. Okay, I'll explain each of these immune cells in detail in the next slide. Anyone has any questions so far? So this chart is basically a really good summary overview of how you would divide and classify adaptive immunity and innate immunity. So you've got your first line of defense as physical barriers, second line of defense, your phagocytes, and third line of defense would basically be your adaptive immune system. Does that make sense, guys? Yes, yep, okay. Let's move on. Now, another difference between the innate and the adaptive is that innate is, yes, it's non-specific, but it's also it also has that fast response. So all of these immune cells, the phagocytes, they'll basically get activated and kill the pathogens within several hours, from any time from 0 to 4 hours. They're really quick, they're really fast. Obviously, they're non-specific, whereas adaptive immunity, so you've got your B cells and the T cells, it takes time for them to really have effect and actually kill the pathogens. It could be any time between 4 to 14 days. Okay. And if we're to look at specific sort of cells, obviously there are your macrophages, dendritic cells, monocytes. By the way, monocytes will develop into macrophages, and I'll explain that in the next slide. You've got your natural killer cells, mast cells, basophils, eosinophils, neutrophils, etc., which are part of the innate, as you can see on the diagram. And you've got your natural killer cells and some of the T cells that sort of share the properties of innate as well as adaptive, meaning that, yes, they can be non-specific, but they can be specific as well. And on the right-hand side, you've got the adaptive immune cells, which are your B cells and T cells or T lymphocytes. This is just a diagram to show you, again, the difference between the different immune cells. Right, let's move on to the next one. And this is the real deal. So what I'll do, please don't get too overwhelmed with this slide. I'll explain it step by step, it's not as complicated or sophisticated as it seems once you really grasp the concept and once you understand the process of how these immune cells come about and what their role actually is in fighting against the pathogens. And I'll explain them in step by step. Okay, and if you think about it, it's actually quite fascinating what these immune cells can each do. Right, so where does it all start? So we've already looked at the different types of immune cells, but where does it all start? Where basically, how do they get born is basically what I'll explain to you using this slide. So it all starts with the pluripotent hematopoietic stem cell. Now it's a mouthful, but pluri meaning multiple, potent meaning potential, hemato meaning blood, poieting meaning creation, and stem cell just means undifferentiated cells. So it all starts with what we call pluripotent hematopoietic stem cell, which is basically where it all starts. It's the ancestors of all of these immune cells. Okay, now when these stem cells are activated, they sort of divide into what we call myeloid stem cell and lymphoid stem cell. Okay, now myeloid basically means bone marrow. So it gets created in the bone marrow. That's what it means. And lymphoid means lymphatic system. They travel through the lymphatic system. Okay, so let's look at them one by one. Myeloid stem cell, obviously will now develop into and mature into many different cells. As you can see, it even develops into platelets, and we all know what platelets are. They contribute to blood clotting, and the myeloid stem cell even develops and matures into our erythrocytes, so red blood cells. And finally, specific to the immune system, it will become what we call myeloblast. Now, myelo, like I said, is bone marrow, and blast means immature cells. So myeloid stem cell become myeloimmature cells, and from there on will now mature into all these different immune cells that we've talked about. Okay, now let's talk about them one by one. So basophils. Now basophils are very similar to mast cells, okay? And although mast cells is not specifically or explicitly laid out in the diagram, basophils and mast cells are very similar. And they release chemicals in response to the presence of pathogens. Okay, does anyone remember what mast cells, the name of the chemical that mast cells release? Let's see if anyone remembers. Yes, very good, Petra. Yes, histamine. So mast cells release the chemical histamine. Now, so both basophils and mast cells release chemicals in response to the presence of pathogens, and the difference between mast cells and basophils is that mast cells are actually fixed in certain locations. So they're either present in the nose or in the lungs, etc., etc. Okay, whereas basophils, these will basically freely circulate in the blood. Okay, that's the main difference between mast cells and basophils, but they're very, very similar. Okay, and obviously by releasing these chemicals, they will trigger inflammatory processes that will basically be the start of the immune response. Yes, they also release prostaglandins. Next you've got the neutrophils. Okay, so myeloblast will also mature into what we call neutrophils. And does everyone remember which type of inflammation neutrophils are mostly and abundantly found in? Is it acute or chronic? Yes, very good. It's acute. It's during acute inflammation that you'll see heaps of neutrophils. Now that's because neutrophils are very fast, meaning that they detect pathogens very, very quickly, which is why they're mostly involved in acute. Now that doesn't necessarily mean that neutrophils are only involved in acute inflammation. They also play an important role in chronic inflammation as well. However, if you were asked what type of inflammation they're most commonly found, then you would say it's during acute inflammation. Okay, so if I were to give you a bit more information about neutrophils, think of them as your patrolling forces. So they're sort of like your police patrol. They circulate freely through the bloodstream, and as soon as they detect pathogens, they'll destroy them by eating them up. So through phagocytosis. Like I said, they're very quick. And how do we know the presence of neutrophils? Well, it contributes to the formation of pus. Okay, so next time you come across pus, immediately associated with the presence of neutrophils. Okay, so that's what neutrophils do. And let's move on to eosinophils. So eosinophils, the first suffix here, eosino, means red color. So it's got a bit of reddish sort of color if you look at them under the microscope. And these are pretty interesting ones because they're involved in killing the pathogens that are actually too big for phagocytosis. So any pathogens that are too big to eat them up, okay, this is where eosinophils will come into play. Now, an example of pathogens that are too big for phagocytosis are parasites. Okay, any parasitic infections, eosinophils will come and do their job. So obviously they will release chemicals around those parasites, and it will eventually kill off that pathogen. Okay, quite interesting, isn't it? Moving on to the next. These myoblasts, so the bone marrow immature cells, also become what we call monocytes. Monocytes just means there's a single nucleus, okay? And these monocytes will then mature into macrophages. Now, these monocytes freely circulate in the blood, okay? And as soon as these monocytes enter the tissues, they become what we call macrophages. And macro meaning big, and phage meaning eat. They're big eaters. They're sort of like monster eaters. We've got some questions here. Yes, thank you, Matt, for answering that. So with the macrophages, obviously they eat up the cells, and think of them as really monster eaters, basically. And it's said that they can actually destroy up to 100 pathogen before they die. So think of each macrophage dealing with 100 pathogen before they die themselves. And it's also said that they can kill cancer cells as well. So macrophages are basically your first line of defense, and they eat up the pathogens. The other thing that they do is they also release what we call cytokines. It's another chemical. And they initiate the inflammatory process as well. And they also act as messengers. They send the message deliver the message to what we call T cells, and we'll talk about the different types of T cells shortly. But they also play the role of messengers and alert the rest of the immune cells. Okay, so macrophages are very important first line of defense. All right, so any questions so far? Was that a good summary of how they come about, how they mature, and what they actually do, each of their roles? Okay, let's move on to the lymphoid stem cell. These are really fascinating as well. So like I said, lymphoid meaning lymphatic. You've got your B cells, okay? Let's talk about B cells first. Now, they're called B lymphocytes because they mature in bone marrow, and I'm sure you've learned in A&P. An easy sort of tip to remember is B for bone marrow. So B cells will mature in the bone marrow, and they will produce antibodies as well as memory B cells. So when it comes to B cells, B lymphocytes, remember the two things, antibodies and B cell or memory B cells. Okay, whenever a pathogen enters the body and the B cells detect them, they will obviously multiply very quickly. They will sort of bind to the antigens. So antigens are antigen generators, so they're pretty much tags that signal the other immune systems as well as the B cells to kill the pathogen. Now, each B cells have specific antigen, and they can be, like I said, they can multiply really fast, so they can have millions of different B cells that can fight against the pathogens. Hopefully that makes sense. And they create what we call antibodies, and this is directly produced by what we call plasma cells. Okay, so lymphoid stem cells, they can develop into plasma cells, and then plasma cells will directly produce antibodies. And there are 5 different types of antibodies, which I'm not going to go through during today's session, but just remember that there are many different types of antibodies. And then you've got the memory B cells, which basically provides protection against future invasions, because as soon as something enters, they will detect it, they will create memory B cells to prepare for the subsequent infections. So they will have all the information that they need to prevent second infections. Okay. Now, while I'm sort of dwelling in B cells, there's obviously what we call passive immunity versus active immunity. Now, active immunity obviously involves things like vaccines, and we'll talk about immunization in the next slide. But what about passive immunity? When we say passive immunity, what does that actually mean? What are some examples of passive immunity? Okay, Elaine says natural, yeah, breast milk. So if any antibodies are passed from the mother's milk to the baby, then that's considered as an example of passive immunity. Anything else you can think of? Yes, very good. Yes, through the placenta as well. Yep. Caitlin says immunoglobulin injection. So sometimes you can sort of retrieve antibodies from elsewhere and then directly inject the antibody into the person so that the person can have the antibodies. Okay, and an example is that there was these cases where when COVID hit, obviously you've had people who've caught COVID, who have fully recovered from them and had antibodies in their blood. So you would draw blood from those people who fully recovered, and then you would sort of filter it and inject the antibody against the COVID into other people. Okay, so those are examples of passive immunity. Right, moving on to, so does that sort of make sense, guys? Do we have an understanding of B cells? Like I said, remember two things, antibodies and memory B cells, okay? Right, moving on to T cells. T cells are, again, very fascinating. So there are actually many different types of T cells. However, for the purpose of this course, we'll mainly talk about only two, and those are helper T cells and cytotoxic T cells. Now, with T lymphocytes, I'm sure you've learned this in A&P, T for thymus, because how T lymphocytes mature is that they will leave as immature cells from the bone marrow and travel to the thymus gland, where they actually mature. Okay, remember, B cells mature in the bone marrow. T cells will leave the bone marrow and mature in the thymus gland. Okay, now like B cells, T cells also have antigen-specific T receptors on each of the T cells. Okay, and whenever there's pathogen presence, they will get activated. And if you look at the different types of receptors, there are what we call CD4 receptors as well as CD8 receptors. Okay, any T cells that display CD4 receptors will become CD4 helper T cells, and any T cells that display CD8 receptors will become CD8 cytotoxic T cells. Now, helper T cells, what do they do? What are their roles? They help activate other immune cells, and when I say other immune cells, I mean like things like macrophages, dendritic cells, cytotoxic cells to kill bacteria. Then they even help B cells make antibodies. Okay, so they sort of work together, they cooperate. Whereas cytotoxic T cells, they directly kill any cells that are infected, any cells that have been damaged, then they even kill cancer cells as well. Are we following me so far? So within T cells, you've got the helper cells as well as the cytotoxic cells. Okay, let's move on. Then you've got the natural killer cells. Obviously, the name itself is pretty straightforward. They naturally kill. So basically, they do two things. They induce apoptosis. So if there's any cells, any healthy cells that have become unhealthy or infected, they'll detect that and they'll help induce programmed cell death. So any cell in your own body that's been damaged or abnormal, they'll just kill them. They'll detect them, bind to them, release chemicals, and kill them directly. Okay, and then there's another very interesting immune cell that sort of matures from the stem cell, which is the dendritic cells. Now, dendritic cells, they're like messengers, okay? They deliver messages. So basically, when there's a presence of antigen, they detect that, they pick up that message and delivers it to the T lymphocytes, T cells, especially the two CD4 T helper cells and cytotoxic T cells. Okay, so think of them as the messenger cells. Right, it's already 9:33. Does that sort of make sense, guys? Was that a good summary of all the different immune cells, what their roles are, how they come about, how they mature? Hopefully you have a better understanding of these immune cells. Was it a great summary? Good. Okay. Right, so let's move on to the next short answer of the week. I believe this was posted both on Teams and Facebook. And I think there was a really good response on Facebook, and I might just actually read that to you, if that's okay. So this student said, immunization is a part of the adaptive immune system, and it can be active or passive. And in active immunization, a small amount of disease organism is injected into your body and it triggers your immune system. So obviously when little bits and pieces of these are injected, obviously they're not live pathogens, okay? They're actually dead. And the body thinks that you've actually got the disease, and it starts producing antibodies against those particular antigens and makes you immune to that disease. That's actually a very good answer. Okay. Does anyone like to add anything to that? If you had this question in your exam, what would your answer be? So first sort of keyword that we'll be looking for as markers would be, yes, it's part of the adaptive immune system. And yes, it's part of an active adaptive immune system. We've got some answers here on the chat. Artificial adaptive involves live dead toxin of a pathogen being injected into an individual, which initiates the first encounter, so the body may begin preparing antibodies for a second encounter. That's very good. Very good, Alana. Division utilized the yep, very good, Caitlin. So basically, immunization is not a treatment per se. It doesn't treat if the person is actually going through the diseased process. It's actually for subsequent future infections, right? Okay, I think I'll just end it here, Matt. It's already 35.
Thank you. It's usually me who goes over. Okay. Hi guys. So I've got a couple of MCQs to go through with you, and then I've got a couple of case studies, which we'll probably go over what Yun has just covered. So that's going to be good to see it in an application. So question 1. So we had this in quiz 1, and I've also posted it in both Teams and Facebook. And so if you can just put into the chat what you think the answer is, and then we'll quickly go through it. Okay, so I think most people are looking at getting the correct answer then. I'm just going to put my pen on. Do we all, so let's just go through a process of elimination. Again, you won't have the time to do this as thoroughly in your quiz because it's time dependent, but this is just to go through it so you can see why the others one is correct and the others are wrong. So we're looking at viral versus bacteria. It's upper respiratory. So if it's upper respiratory tract infection, what kind of structures would be involved if it's an upper respiratory infection? What do you think would be infected? What cells would be inflamed? Yes, Sarah. So the sinuses are involved. Tonsils, throat. Someone has a microphone on, I think. There's a bit of echo. Yep. Throat, how far down? Not quite, Kiri. Bronchi is going to be lower respiratory. So Alana, that's right. So larynx is kind of the cutoff point. So once you go below the larynx and you get kind of into the trachea, it's now going to be lower respiratory all the way down to your alveoli. Okay, so this is viral versus bacteria, so it's infection. So based on that, would you be able to discern the difference between a viral and bacteria accurately with a body temperature? So if you just took their temperature with a thermometer, would you know that it's a virus or bacteria? Yeah, that's correct. So it's no, you wouldn't be able to. So that's incorrect. Okay, I'm going to jump a couple, then go to D. So we know that D, C-reactive protein, hopefully you know that that is released in response generally to inflammation. So, viral and bacteria infections will induce an inflammatory response in your upper respiratory tract. That's why it becomes inflamed. That's why you get laryngitis. That's why you get a sore throat. That's why you get sinus infections or the sinusitis, which is inflammation, or inflamed nose. That's why it goes red and starts running. So would you imagine that your C-reactive proteins is an accurate measurement of a bacterial viral? What do you think? Yes, also no. So that's going to be out. So it's really left with these two. Now I'm going to ask you this question. And we've been through this for the last 2 years. In terms of COVID, what is the most accurate measure? What's the most accurate investigation that will definitively tell you that you are infected with COVID? We've probably all had it. PCR test. So PCR is a swab. They stick a thing into your nose and your mouth, and that is given the genome of the virus. And so the most accurate test, if it's going to be an infection, is going to be trying to get a respiratory infection, somehow trying to get a sample of the sputum. So if it's a lower, you try to get your patients to cough up some sputum. If it's an upper respiratory, you probably can get it from the nose or mouth, okay? And then the PCR is just the method of getting the information. So you've still got to, I'm sure all of you have had a PCR, or you've done your rat test. This is a swab, essentially. It's swabbing the up your nose, nasopharynx, or the back of your throat, oropharynx. So the correct answer would be a culture. Now, white blood cells, it can be fairly accurate, but it's not definitive. It probably, bacteria infections would cause white blood cells to go up, viral possibly to go down, but it's not super accurate. It's a bit like in the cancers as well. So if you were suspecting a prostate cancer, what test would be indicative of possibly a prostate issue? PSA, that's right, Kiri. That's correct. So PSA is a blood test, which is just an antigen, but is it definitive? Is it 100%? What is the 100% investigation that would definitively say something is cancer? There's only one. What's the only one thing that a biopsy? That's right. Well done. So it's a bit like this. The only way you definitively know whether it's a viral bacteria is to do a culture swab. Okay, so hopefully you can see the answer and why it is the correct answer there. Okay, next question, question 2. Again, this was in the quiz. So this is in adaptation. This is module 1. So we've got a 50-year-old man. He was diagnosed with hypertension 10 years ago and causing the heart to pump harder to maintain tissue perfusion. Over time, what would you expect to find? What's the answer here, guys? A, B, C, D. Okay, so it looks like most are going A. Okay, all right, so let's go through it. So the first thing you need to think about is what's the organ that's going to do the adapting. So we've got, let me find my cursor, here we go. So we've got the heart, you've done A&P. What is the heart? What's it made up of? The heart is essentially all muscle, not completely, but pretty much the whole thing's muscle. Okay, well done, guys. So you should be able to figure out now what, in terms of tissue, what does the heart do to adapt? So what has the capacity of muscle in response to adaptation, in response to stress? Muscle can't replicate, it can't copy itself. Okay, so what does that rule out? If you're, as a cell, generally can't, it can't go through mitosis, so it can't be hyperplasia. Okay, so hyperplasia is out. Okay, so we're going to be left with one of these three. Atrophy means smaller, so that's probably not going to be working because muscle would want to get bigger when it's stressed out. Okay, so we're left with these two. So now you have to think about, well, is hypertension a good thing for the heart to be responding to? at least chronically in this case, is it 10 years, or is it detrimental? Okay, so this is where your answer is going to come about. So the answer is it's going to be pathological, because hypertension for 10 years is actually a pathology in and of itself. Okay, it's not to say if you go through periods, acute periods of hypertension, that your heart won't react to it, but if it's chronic, so every day, throughout the whole day for 10 years, your heart is responding to hypertension, it's going to respond in a kind of a maladaptive way. And so there's an interesting question that I think some students posed is, well, what about an athlete who's exercising? You know, they're doing cardiovascular exercise and they would be having hypertension when they're exercising. Why don't they get pathological hypertrophy? Well, interestingly, there's something about exercise on the heart, the way that the muscle in the heart muscle or the myocyte adapts. It seems that in an exercising heart, the way that the muscle gets bigger, it goes long proportional to width. Okay, so therefore it's actually a good advantage adaptation. Whereas in hypertension, so the heart is exposed to high blood pressure for periods of time, it seems to get fatter relative to long in terms of the myocyte itself. And when it gets fatter, it then moves into a type of cardiomyopathy, which is kind of I think it's a hypertrophic myopathy, which means the heart isn't overly efficient in its beating. Okay, so this is just illustrating that you can actually get hypertrophy of the heart in an athlete's heart and it becomes super efficient. That's why they beat slower. But in a pathological, the heart actually becomes maladaptive and it's not a good outcome for the heart quality. And then you'll go down into heart failures. Okay, was there any questions with that? Did that all make sense, guys? I'm not sure, David, in terms of rowers. I couldn't answer that specifically, but I think for most athletes that put a lot of cardiovascular load on them, there's something to do with the whole systemic system that's going through exercise that has a protective effect on the heart, opposed to a detrimental in cases of hypertension. All right, so now we move to the case study on Mickey. So this was last week's one in the immune, specifically I think 3.2. So we had a guy that was playing soccer. He got pain in his right foot. He then became hot and itchy all over. He jumped in the pool, didn't help. He started to have trouble breathing, trouble swallowing, and then right at the end when the paramedics arrived, he got low blood pressure, high heart rate, high respiratory rate, started to develop stridor and cool and moist skin. Okay. So guys, what do you think is happening to Mickey? So this is the first question. That's right, Mungsuk. It's athletes. It's a physiological hypertrophy. That's correct. He stepped on a bee. That's right. That's right, Anna. That's correct. He stepped on a bee. And what do we move into? We go to an allergy, an allergic reaction. Firstly, before we get to anaphylaxis, what type of hypersensitivity is this? 4 types. Which one is it? Type 1. Excellent. So it's the first question. Let me see if I can write it. What do you suspect is wrong? It's a bee sting, which is developing a type 1 hypersensitivity. So this kind of answers this one. So it's not autoimmune, it's just a hypersensitivity. Autoimmune is where you stop recognizing self. Okay, so you learn, your immune system loses that ability to discern what's self and what's foreign. Okay, and it starts attacking its own self. Arguably, type 4 hypersensitivity would be a form of autoimmune disease, such as type 1 diabetes. Moving on to this question. So this is an important one. What do you think here, guys? Do you think it's likely that Mickey has been stung before, or is this the first time he's ever been? Okay, good. That's excellent. All right, so it's a type 1 hypersensitivity disorder. We've said that. So what cell is implicated with a type 1 hypersensitivity disorder. I'm just reading Alana's. Okay, so Deborah, correct, mast cells. And what type of antibody sits on the mast cell? Does anyone remember? IgE, very well done, Alana. So IgE, that means the IgE antibody, okay, is now sitting on the mast cell. So let's say this is the mast cell. It's filled with these granules, as Ewan asked you guys. So what are the granules that the mast cell is filled with? It's just packed with these granules. What are these granules called? Histamines. Well done. So what's the process that we call a mast cell vomiting out all these granules? What do you call that process? Degranulation. Well done. So this mast cell has these things on them. What are the things that I'm drawing on this mast cell? What are these things I'm drawing on this mast cell? Antibodies, specifically IgE antibodies, and they are primed, means they have been sensitized to what in this case? What are they sensitized to? Not so much bees per se, close. Yeah, so it's something in the bee sting. So there's something in the venom of the bee when it stings you that your immune system sees as foreign. It primes it through an adaptive immune response, and then you produce antibodies against it, which then sensitize the mast cell, which then answers this question that yes, he has to have had a stung before because he's primed to it. So that means anytime that he has a re-exposure to a bee toxin, if it encounters, if the toxin, if this is the toxin, these circles that I'm drawing, if that comes in and it binds to the antibody, which is primed to the toxin, it will tell the mast cell to degranulate. Okay, so that's then going to move to this. So in his case, the degranulation, what does histamines do? What does histamines normally do in the case of inflammation? Lauren, the only time you'd expect this level of detail if it was a SAQ question. Yep. So you'd get vasodilation particularly, yeah, vasodilation and increased vascular permeability. So that means that blood vessels anywhere exposed to this histamine would start to dilate and become leaky. Right. Now, in the case of Mickey, he does this everywhere. So he vasodilates and his blood vessels become leaky in his whole body. So now he's got a type 1 hypersensitivity reaction systemically. And we call this, what do we call this? We call this anaphylaxis, right? Now, paramedic on the scene, what's the treatment? So EpiPen, which is adrenaline essentially. So adrenaline, hopefully what you've known or you will know by module 7 is adrenaline is a very strong vasoconstrictor. So that will hopefully get his blood pressure back up and it won't have the issue and cause bronchodilation, because what's histamine's effect on smooth muscle in the bronchioles? So that's a good question, Deborah. Histamines will cause bronchoconstrictions. That's causing problems to breathe. That's why with anaphylaxis you got significant problems breathing. There was a question by Deborah. Why is this systemic? That's a good question. This is the $1 million question, which you want $1 million answer for. There's something with individuals that's just predisposes them to a systemic response. Probably genetic in background, but I can't answer that. Okay, moving on to Ricky. But well done, guys. You did well with that case study. So Ricky, this is in topic 3.3. So Ricky is 6 month old. Not year old. 6 month old. He is being given this DPT. Okay. DPT stands for what, folks? It's a tri-vaccine. Diphtheria is D, correct? What's pertussis? T, tetanus, D, diphtheria, P, pertussis. Pertussis, also known colloquially as whooping cough. Well done. So let's quickly go through and I'll explain the question or the answer. I'll give you the answer for this and this together. So this is a tri, it's 3 in 1. Okay, well, actually I'll start with pertussis. Pertussis is whooping cough. That's the sound that they make when you are infected with this bacteria. This bacteria attaches to the cilia. Where's your cilia? Where's your cilia located? Throat. So basically trachea, bronchioles, right, upper respiratory, also a bit of lower respiratory. So not smooth muscle, Hamdi. That's a bit deeper. The cilia are on your epithelial cells. Okay, so bacteria binds to these guys, releases a toxin. The toxin causes the paralysis of cilia. What's the problem there, guys? What's the problem with your cilia in your airways not working anymore? Not so much irritate. You just can't get rid of things that that you've breathed in. Okay, so therefore it can't get rid of these things you're breathing in. So what kicks in? Something will kick in when you have paralyzed cilia. You get a strong cough reflex. So now the cough reflex comes in and it's very profound. That's the whooping aspect to it. So in America, before the vaccine came in, approximately 10 to 20,000 people died per year of whooping cough. Okay, so that's the context of it. Diphtheria is named diphtheria basically, or the derivative of diphtheria means leather. And so the back of the throat becomes this leathery appearance. So if you were to look in, it looks like there's a chunk of like a boot, like, you know, the leather on a leather boot at the back of your throat near your tonsils. And that just starts to kind of strangulate the upper respiratory tract. This was especially bad for children and it caused them to asphyxiate. So a very horrible way of dying. Okay, so that's diphtheria. Numbers in 1920, about 15,000 people would die per year of diphtheria. Again, not both horrible ways of dying, horrible ways of dying. And then tetanus. Tetanus is basically a toxin that becomes a neurotoxin, and that tells the muscle nerve connection to become activated, and you became. It's called a spastic toxicity. So all the muscles lock up, and it's a very horrible, again, a very horrible way of dying. I'll give you a quick, well, let's answer the second one. What is the mechanism of this vaccine? Does anyone know? Well, in the case of both, all three, the thing that causes the issue are the toxins. I think tetanus is the exotoxin, so it's a gram-positive bacteria. Pertussis, I don't think it's a gram-negative. I don't think it's an endotoxin, but it's something that the bacteria releases that causes a cilia paralysis. And the diphtheria, I'm not sure if it's, but it's the toxin of the bacteria. Does anyone know, therefore, what's the basis of the vaccine? What's the category of the vaccine with the toxin? Not so much the bacteria itself. Yeah, toxoid, that's right. Well done. So an interesting story, horrible story, but interesting story. Early 1920s, when I say earlier, probably around the 1920s. How was diphtheria? How was diphtheria given? This is mostly to children because that was the cohort that was most heavily affected and that would die of diphtheria. Does anyone know the method of how the vaccine? It wasn't actually a vaccine. It was a immunoglobulin, actually. Yeah, horse. That's right. So it wasn't actually a vaccine like we use now. It was basically give the horse diphtheria in a small amount, allow the horse to react to the diphtheria. So a small amount. The horse would, in its adaptive immune response, produce a lot of what? What is the horse going to produce a lot of to counter this diphtheria antigen? And when I say the diphtheria, I mean the toxin of the diphtheria. Antibodies. So the horse produces a ton of antibodies. So then you take off lots of blood from the horse, put it in a centrifuge, spin it down, and you can get the plasma. And so what you do with the plasma, what's in the plasma, guys? And this is where the antibodies come from, because the antibodies is part of the humoral adaptive immune response. Humoral means fluid. So plasma is where you find the antibodies. So what you do now is you give the plasma to the kids. Quite effective, quite effective. It dropped the rate significantly. But there was a horrible case, I think in Ohio, no, maybe Iowa, I think, where the horse that they were doing this in this one part of Iowa developed tetanus, and they mixed up the blood and they gave the antibodies, the plasma, to the children, but it had live tetanus in it. And so about 10 kids died from tetanus due to this method of giving the vaccine. Why am I telling you this? Well, we have a lot better, more refined techniques of giving vaccines than we did 100 years ago. And so now we use, in this case, a subunit vaccine. So the DPTs are actually a subunit vaccine, which has been just isolated purely for the subunit now. So we're not using this convalescent plasma that we saw with the horse. And then we're just getting much better with our refinement in the vaccine. So it's just giving you an idea of history of how we've come along in the history of vaccines. 200 years we've been using vaccines, are very successful, arguably the second best medical breakthrough ever. So highly successful. Moving to the next question, DPT, how would you give it to a 6-month-old? How are vaccines given to, well, we know how we give it to adults, yeah. Why do we give it to the upper thigh and not the arm? Why not the arm? Why not IM in the arm? Yeah, more muscle, that's right, good job. Next question. You give the vaccine and you get redness, you get pain, you get fever next day, you get myalgia. Why? Why do you get these side effects? Is this a bad thing? Very good, Anna. So it's the immune response. So it's what your body is supposed to do when it's responding to something that's foreign. That's right. So the analogy that I like to give is when people say that's a side effect of a vaccine, that's like saying, I went to the gym 2 days ago and now I've got sore muscles. That's a side effect of going to the gym. Well, it's not. It's just your body's countering the stress that you put on it, and it's building new muscle proteins. And so unfortunately there will be pain and DOMS that will go with it. But that's not a side effect of gym. That's just telling your body's doing what it's supposed to do. Okay, so it's important when you educate your patients, you tell them this is not side effects. There is side effects. They're not perfect. Nothing that we will do in medicine is perfect. There's going to be side effects. There's going to be some detriment to things we do, but the cost benefit is always going to be outweighed, hopefully. So we have to be important as nurses who give the education to the patients, that you tell them that it's not a side effect of the vaccine. It's just telling your immune system that you're going to fever, you might be achy, you might even feel terrible. This is telling you your immune system is reacting to it, which is a good thing. Now, moving to these last two questions. So we might run out of time here, but I will try to just get them in. So you guys are welcome to go if you need to go somewhere else, but just these last two questions. Does it cause autism?
Sorry, Matt, you might need to extend the time because some students might get kicked out.
Okay, let me see if I can quickly do that on, so just bear with me for 1 second, guys. I'll just change it in the calendar. Okay, I've just sent it. I've just updated it. Hopefully you won't get kicked out. Okay, so where did the autism thing come about? Does anyone know where the whole autism and vaccines came about? Because I think, again, it's important to you guys know, because nurses will be given more education than doctors. You'll be given the vaccine. Doctors don't generally give the vaccine. Yes, old article, Nari, that's correct. It came from a gastroenterologist called Andrew Wakefield. He was a UK gastroenterologist. He did a lot of early work on looking at the link between autism and gastrointestinal complaints. So that was kind of his area, and that's a known phenomenon. People that are on the autism spectrum are known to have certain gastrointestinal complaints, challenges, and so that was already known back then. Now, what happened was he was doing research in that space, and he was kind of looking at the possibility of viruses or infections that would make these manifestations worse. And so then there was, concurrent to this, there was a class action between maybe 10 parents in, I think, the UK, who were taking a pharmaceutical company to court, and they approached, or the lawyers of these parents approached Andrew Wakefield to say, would you be willing to represent, from a academic standpoint, this case? And so they gave him, I think, maybe £50,000, and this kind of informed the article that he and others published, which was in the Lancet, and it kind of suggested that there could be a link between the MMR vaccine, specifically I think the measles MMRs against 3-in-1, measles, mumps, rubella, the measles part possibly having a link to autism. Now that threw a whole lot of fury out into the public, and subsequently parents stopped giving the MMR vaccine and so forth. The other investigators looked into it and found that it was questionable. Some people started to look at the paper. He didn't declare his conflict of interest. There was fraudulent data on it. So Lancet retracted it. All the authors jumped off it because Andrew Wakefield didn't tell them that he got money and that he falsified some of the data. And but unfortunately, the rabbit's out of the, I don't think that's a correct analogy, but you know what I mean. The genie's out of the bottle. I'll use that one. So basically now that's right, the damage is done. But a lot of studies have looked into it, and they've looked at observational work where they've got a non-vaccinated group versus a vaccinated group. They've done observational data to look at autism rates, and they've found that's identical. They've tried to look at where certain researchers that felt that the vaccine was problematic. There could be ingredients within the vaccine, and they've removed all these out, like thimerosal, pulled all these out. So basically, and again, it doesn't change anything. And so basically, that whole autistic link to vaccine has been significantly debunked. There's not even one paper that has any suggestion that has a link to it. So again, for whatever reason, vaccines have been tainted, and you probably, I'm sure you've seen how much controversy has been in the COVID vaccines with these kind of anti-vax movements. So it's a very challenging space to be in. But again, it's important to note that vaccines like penicillin, like aspirin, like pick your drug, doesn't have side effects. Yes, some people will react in a way to anything that can be given as a drug. So 1 in 1,000 people will react into anaphylaxis with penicillin. Okay, but again, the benefit of penicillin has been enormous. Same with vaccines. Unfortunately, some people will have anaphylaxis or have serious immune responses to it. But again, it's a public health thing that is for the greater good of the majority. Okay, so that's just something to be mindful of when you are talking with friends, family, patients around vaccines, that it's a very charged issue. So you've got to just be careful with the way you word certain things. Are there any questions? Yep, that's right. And autism is a separate discussion in itself, and so because neuroscience doesn't really know what autism ultimately is and what causes it and what it means, it becomes a very emotional thing for parents or loved ones. And so when we become emotionally charged with something, sometimes we look at things differently. And so with that link, it's very difficult. And you wouldn't want to go down this path with a conversation with a parent with that, because it just wouldn't go anywhere. You'd probably be better off suggesting going to certain resources, government resources and so forth, where they can look into that particular question. Considering that he got a reaction in the first case, would you suggest a booster is important? What do you think? So if you were, let's say in your first dose, you had a response like redness, pain, fever, would a second dose be useful? Yeah, again, it's just telling you that your body is reacting to it. So it's not, if you were to get anaphylaxis, that would then have to be a conversation that the person would have with an immunologist, where they're a specialist in the immune system. Okay. All right. Are there any other questions around vaccines? There's going to be quite a lot of questions in your final exam around vaccines, how they work. So in terms, I think I've answered most of those questions there. So Kiri, I think the way it sits currently, they initially looked at if you had if you were infected with COVID, that was considered equivalent to one shot. It doesn't seem, for whatever reason, and I don't know if they know the fuller reason for this, but it doesn't seem that Omicron is overly good as a robust and a diverse immune response. So if you were to get COVID Omicron, presumably if you got that December, January and on, you could make the argument that it was Omicron. That doesn't seem to have such a robust and diverse immunity as, say, the previous versions like Delta. I'm not sure why. So you may not be overly well protected if you got Omicron to a later strain, possibly, or even Delta. That's where the data currently sits. So I would say, following the health advice, is to have your three. Definitely have your 3 doses. The first, does anyone know what the first profound medical intervention that has saved the most lives? Antibiotics is 3. So just measles on their own arguably has saved between 100 and 200 million children since the 1920s. That's a lot. 120 to 200 million children are alive today because of just the measles vaccine. The number one medical health intervention is sanitation. So just water, having sanitized water. And you know what, which is interesting, when they brought in sanitization, so when they brought in public health policies of chlorinating water and separating the effluent into a different part of town, there was actually a backlash to that. So back in the day, 1800s, people used to just get their toilet bucket and throw it out on the street, and then that was the way they disposed of it. But then public health policy was, we wanted to bring pipes into your house to take the sewage away from the water. And there was actually backlash and protests against that. So it just shows you how people can be when there's change. People don't want change sometimes. And we wouldn't look back there and say, wow, I really wish I was still throwing my effluent out in the street every morning, because that's such a better way to do it. Anyway, okay. It just shows you how the mind works when we become emotional. That is disgusting. That's right. Okay, guys. Thank you. Hopefully you've enjoyed your seminar. Have a great week. Remember, the quiz is Wednesday to Friday. And next seminar, next week, you and I will go through your case study assignment. So please attend. Have a great week. Be good, and don't mix up your effluent with your drinking water.
Bye, guys. And can I just quickly remind you guys to really attend your tutorial